So for the next yes, our next lecture is Dr. Fabio Savastano, and Fabio Savastano is highly experienced medical doctor and orthodontist with extensive teaching and clinical expertise in neuromuscular orthodontics. He got his MD degree from the University of Naples and his specialty degree in orthodontics from the University of Padua. Since 1988, he has focused on applying the principles of neuromuscular dentistry to orthodontics based on a unique diagnostic and treatment protocol. His contributions to the field have been widely recognized with numerous lectures and courses delivered globally over 1,000 doctors since 1989. His current role as Associate Professor and Director of the MA program in Neuromuscular Orthodontics and Craniomandibular Orthopedics at the University of OrthJaume in Castellón, Spain. Without further ado, I would like to invite Dr. Fabio Savastano to make his presentation.
Good evening, doctors. This is Dr. Fabio Savastano from Italy. I'll be speaking a little bit over half an hour with you on primary and secondary tongue thrust identified with surface electromyography. I would like to thank Professor Marian Constantinescu for organizing the great effort he's giving for this International Virtual Conference INNOBIODENT 2024. From this first slide, you can see the first logo up here is the ICMO logo. The ICMO logo is because I am a member of the International College of Craniomandibular Orthopedics. I've been a member for quite some time. This is a very interesting international association. If you want to become a member and have more information, you can contact me directly on the email. Then we have another logo here, Universitat Jaume I, is the logo of the university where I teach a master's in neuromuscular orthodontics. Other teachers include also Florin Constantinescu, which is an excellent prosthodontist from a neuromuscular point of view. I'm also a member of the ERS, the European Respiratory Society. I know that the majority of you are very interested in the respiratory problems of our patients because it is a reality. And if you want to have more information on me, you can go on the savasystem.com or dentalsciencemaster.com websites. You'll find a lot of information about our courses, about ICMO, and you'll find links probably to other sites of interest. So we can start talking about what is included in my lecture today. This is my book. It came out in November 2023. I recommend you buy this book if you're interested in what I'm going to talk to you about, or if you're interested in neuromuscular orthodontics. I have no financial interest. I do not receive royalties of any type, so I can really promote this book quite freely. The majority of what I'll be talking to you about today and reassuming what I'll be talking about today is included in this first edition. Also, the references of what I am talking about are not included in the lecture for a question of space and time, and you can find them all in this text. So we can start with one important consideration. The ideal function is linked to ideal swallow. What does this really mean? It means in a very simple matter that the idea that function is linked to single anatomical aspects of the human body is something that is an old idea we had when we went to school. Well, I went to school 45 years ago, so that's quite a long time. So when I was in university, anatomy was always linked. Single anatomical parts of the human body were linked to function. Now we need to discover a new neurobiological model of the human body in which function and structure have a tendency to be the same thing. That means that the stomatognathing system is not an addition of anatomical components from a functional point of view, but we see function of the stomatognathing system. That means that we cannot have a correct function of the tongue and have at the same time a good occlusion. If we have a malocclusion, we'll always have a defect, an alteration of tongue swallow. There is a discussion on what altered tongue swallow is, if it's not a pathology or not. From my point of view, anything that is not strictly physiological is pathological. So this is a very slippery field in which a lot of oral therapists try to define a new space in which they can define an irregular swallow. Okay, an irregular swallow is probably something that for them probably not pathological. For me, anything that is not fully physiological is pathological. So this said, let's go to the next slide. So what happens when there is a tongue dysfunction? Can tongue dysfunction play a role in creating malocclusion? This is another everlasting debate. I've said this before, I'll repeat it right now. I think this is very important. There are a lot of general pathologies of the human body that bring alteration of tongue thrust that as a consequence create malocclusion. This is the proof that if something from the central nervous system influences tongue function, we get a malocclusion. So we'll see that where there's trauma, for example, of the central nervous system, or where there's a genetic alteration of function that is linked also with alteration of function and cognitive function of the central nervous system, we have an alteration of tongue function, and we have tongue thrust and alteration of occlusion. So this has already been demonstrated. So there's nothing new in here. The whole lecture focuses exactly on this point. Is there something that we're not able to diagnose that determines the creation of an intrinsic alteration of tongue function given from the central nervous system in certain individuals, which creates an impaired swallow and determines a malocclusion? Is that possibility there? Is that one of the explanations for which we may have relapse? Because for sure, all of us here have relapse in creating new occlusions. These relapse sometimes are linked to impaired swallow. So here you can see on my left side, on the left, you can see two malocclusions. One is a skeletal open bite malocclusion in which there is a tongue thrust, and the question is there a way that I can study the tongue thrust in an open bite individual? And the picture just right under it is another primary tongue thrust in which we have a very strong tongue function with a tongue thrust that determines and creates a class 2 occlusion with no overjet and a lot of spacing too. Are these entities, do these two entities have something in common? Can I find something in common which is primary to both these cases? Are all these cases considered primary, or just a certain percentage considered primary? I'll say, what is the whole point? The whole point is that if they are primary, there is actually no treatment. And I've had orthodontists, my friends, tell me that they've had cases in which they've had relapse. They tried to treat them again. They tried to re-educate the tongue as much as they could, but they kept having relapse. So the idea I have is that if I can figure out before treatment the type of swallow disorder that they have and define it if it is primary, I can avoid, in certain cases, certain types of treatment, and I can change the aspects of treatment and adapt them to a much higher level of reality for the individual. Trying to explain that sometimes we cannot have a complete restitutio ad integrum. That means we cannot have, again, a complete and physiological oral function. So, while orthodontics can relapse in some cases, it still, in general, as a community, fails to address the possibility of a primary cause for tongue dysfunction. This is very sad because I talked with a lot of orthodontists, and I asked them, don't you have tongue dysfunction cases in which they relapse? And, maybe they're about 4 or 5% of your cases. And they say, well, quite frankly, they don't want to work hard to find the cause. They know it's difficult. They probably call it an endogenous type of tongue thrust, some of them, of course. And they tend to blame the patient for not doing enough OMT, oral myofunctional therapy. I don't find this a good reasoning. I'm used to never giving up. So I'm here to try to define and find the cause for that 4, 5, 6, maybe 7% of individuals that will always relapse. Okay, so how can we do our testing? What can we do to study the oral phase of swallow? So this is the K7. This is bioelectrical instrumentation we use. This is a preamplifier for electromyography. This is sonography for TMJ. We're going to skip talking about this today. And this is a sensor array that actually records mandibular movements based on a magnet that is stick to the lower arch. This computerized mandibular scanning system has been for quite some time on our markets, and this particular system is practically the only one that has the most advanced features and can be in one way personalized, and we'll see that in just a few minutes, personalized to study swallow disorders. Here is another picture. Here we see the preamplifier, electromyograph preamplifier. It sticks to muscles and it can test muscles. In this picture here, you can see the temporalis, the masseter, and the submental muscles being tested. We can test the sternocleidomastoid and other muscles too. Actually, this surface electromyography system can be used to test any muscles of the body, okay? But for our interest today, we like to put also the electrodes on the lower or upper lip, okay? Upper, to test the upper or lower perioral musculature, okay? This is very, very important. And we can use, we can test up to we can test up to 1, 2, 3 couples, 4 couples of muscles every time. So you don't see it here, but here we're testing also the posterior temporalis that you don't see in the pictures. So you have 4 muscles tested bilaterally with the system. And what is interesting is that this system, when used with the sensor array and the magnet on the lower arch, will record mandibular movements and surface electromyography at the same time. And that is exactly what we need to study swallow, because we want to know what is happening to the mandible and where is the mandibular movement during swallow. Okay, so this said, all the system hooks up to your laptop. You have a program, and you can really analyze a lot of things dynamically and study your dynamic occlusion. But most of all, we are interested in certain pictures that we can obtain when studying primary or secondary tongue thrust. Secondary would be adaptive tongue thrust. Okay, so secondary is what you're most used to see, where you have, for example, an increased overjet in an individual with a class 2 occlusion, and of course there's a big gap in the front, and the tongue adapts to retain for the conservation of the swallow process, which is a normal reaction to the change to the malocclusion, which is an environment that reduces the space of the tongue. Okay, and what we are doing now is that first I want to show you what a normal swallow would look like. And the first thing I'd like to show you here is that we have a VSS. That means this is a voluntary swallow of saliva sequence. This is a sweep type scan. That means it's a scan that moves from your left to your right. And we're testing all these muscles, which are the temporalis muscles, the masseter muscles, the lower perioral muscles. Remember I showed you in just in the picture before. And LDA would be the digastric, or better called the lower submental musculature. And at these 3 lines here represent mandibular rest position. Okay, the patient is relaxing, and at one point we tell the patient to swallow. So the patient, you see the line close the vertical gap. That means the patient goes to close when he's swallowing. And then we ask the patient to tap in centric occlusion, ICP of course, centric occlusion, to understand where is the vertical level of centric occlusion, to understand if the patient has swallowed in centric occlusion. Okay, so this is typical of what we would do when studying a voluntary swallow of saliva. Obviously, when the patient closes their mouth, they come forward, so you'll see the red line come forward. Here there's a slight lateral deviation to the left, because this is the lateral line. We're not going to talk about that today. Okay, so look also the voluntary swallow of saliva. The duration is a little bit over 1,150 milliseconds, a little bit over a second. The main part of the swallow process, which we can see by the activation and deactivation of the oral perioral musculature and the oral and the stomatognatic system musculature participating for deglutition. So the lateral temporalis, masseter, okay, anterotemporalis. So this is the normal swallow. Let's see the same patient with a normal swallow during an SSS, which stands for spontaneous swallow of saliva. Okay, well, why do we check the spontaneous swallow of saliva? Well, first of all, because As Professor Erkatin in Turkey describes and has described in a thorough way, this is a different type of swallow. It lasts less. You can see here we're about at 10 milliseconds. It lasts less, so it's faster than a voluntary swallow of saliva. And in this case, we see the sequence and the onset of the activations are all very close. And again, the perioral musculature is very little or non-activated. That means that the perioral musculature does not really actively participate in the swallow process, okay? And so we see the temporalis act and activate. That is because from the rest position, the patient brings the mandible towards central occlusion during the initial part of the swallow. Also, the masseters are activated. It could be because the tongue is slightly between the dental arches in this phase, and so the masseters are activated, but this is more or less a normal swallow that you would see in a spontaneous swallow of saliva. Okay. This is in a tongue thrust in patients with secondary adaptive tongue thrust of saliva. For example, in a patient with a class 2 occlusion and a big overjet, of course the tongue has to adapt. And of course, the whole swallow sequence, the whole oral phase lasts longer. Look, about 2.8 seconds. You've seen these kids go swallow like a never-ending long swallow. They use up a lot of energy. That means it's a less ergonomic, a less functional physiological swallow. And what you can see here is that there is an immediate activation of the perioral musculature and the temporalis. They all activate on this line, but the submental musculature activates, yes, at the beginning of the main line, green line you see here, but mostly towards the end of the whole swallow sequence, okay? And their output is quite high, okay? And this is an adaptive tongue thrust. And we'll see what happens when we continue our discussion and go check again this adaptive tongue thrust in a voluntary swallow of saliva. It again lasts a little less in time. It's still more than what you would expect, and it still has that late strong reaction of the submental musculature, and it still has the activation of the temporalis. So the adaptive tongue thrust is pretty easy to visualize. Usually this is what you get. And when we test normal individuals with adaptive or normal swallow, okay? But adaptive means these swallows are a reaction to the environment, okay? So they are normal individuals. If we change the environment, we have a 99% chance that even without any type of OMT, we have a normalization of the swallow process, okay? And if we just take a look at this little table here, this is what I'm talking to you about here. In the secondary tongue thrust, the onset of the perioral musculature is close to or overlaps that of the submental musculature, and that the submental musculature total output is always higher than the perioral musculature total output. Okay, this is what a secondary tongue thrust would look like. Okay, now what I want to talk to you about today, and I'm going to show you a clinical case, is what usually happens in a primary tongue thrust. What are the differences from an electromyographic point of view? And I'm going to choose a open bite individual, okay, because there is no difference in the sequence of activation between open bite, normal bite, competitive or not lip competitive patients. These characteristics are, from my point of view and what my research is trying to demonstrate, independent from facial type, okay? And in primary tongue thrust, we'll see that the perioral musculature activation onset anticipates almost half a second before the submental musculature onset. And that the submental musculature onset and output, the total output of the submental musculature is inferior to the total output of the perioral musculature. Okay, so here is our clinical case. I have about 10 minutes to discuss this case with you. So this is a severe open bite individual with a swallow disorder and a skeletal class 2 malocclusion. Okay, obviously the results can be obtained only with surgery, and this is, the situation. We have also problems with teeth, so it's also a general dental problem. But I start working with another dentist on this patient, and we have a big open bite here, and this is our patient here with non-competent lips. I am asking her to bring the lips together, and you can see how the perioral and mandibular musculature here is very well activated. Okay. This is the big overjet we have. This is the shape of the upper dental arch, which is, of course, it's full of problems, dental problems, and the shape also. And this is the lower arch. There's a lot of dental work to do. Of course, there are going to be some teeth missing. As you can see from the panoramic X-ray, we have treatment and teeth missing, so we need an implant. So it's a little complicated. We start working together on this patient, and after we change and prepare the patient for occlusion, we get our results after surgery. And this is what it looks like. And patient is very happy, wonderful. I'll show you the occlusion in just a second. We have changed the life of this individual. Of course, before you ask me, we've had ENT evaluation before treatment, after treatment. ENT was, we did a fibroscopy to check everything, and she was breathing with her nose before and after maxillofacial surgery. Of course, this type of occlusion is treated in two phases. The first phase with a SARPE, that means a surgically assisted rapid palatal expansion. And then we did a bimaxillary treatment here, surgical treatment. And this is the result, which is an important result, made this patient very happy. And here are other pictures of the face. And this is the final occlusion. The final occlusion is very good. We like it. But we're in 2012, and I check my patient in 2012, and I asked her to swallow, and I am not convinced that the swallow is good. I know she has not swallowed correctly for years, for all her life probably, and I sent her immediately after surgery to the best logopedic school in northern Italy. And so they start working on her, and she's very motivated. And she'll do 5 intensive years of OMT. That means she starts with the classical logopedic exercises, and then at the second or third year, she switches to another expert, which does more OMT, classical, modern OMT, and that will accompany her and her exercises. She's very motivated for another 3 years. So it's over 5 years OMT. And I check her in these years, but in 2017, 5 years after surgery, I put up a transpalatal arch to be sure I don't get an upper maxillary contraction, because I'm still worried about the tongue position and the tongue posture not being backward enough to keep remodeling my upper maxilla during involuntary swallow, okay, the spontaneous swallow of saliva. Because look, she knows how to swallow perfectly after 5 years. Her OMT treatment, the OMT treatment she went through for 5 years gave fantastic results, and we'll see that. The voluntary swallow of saliva is perfect, but what happens in all that other part of the day in which you're not conscious of your swallow? So I look at her now and I see a little bit of spacing. Yes, this worries me a little, and this is 5 years after surgery. Of course, she's very happy. She had 2 children. She has a great life. But I know she's going to relapse. And I don't give up so easily on my patients. So she lives far away, over 250 kilometers. And I'm lucky she comes over and comes to my office where I take these pictures in 2017. And I also check how she's working and how her occlusion is. And I see that she has a very good freeway space, 2.4 millimeters, which is from a rest position to centric occlusion is a good freeway space. And that her physiological trajectory to centric occlusion is about a millimeter behind the most physiological ideal path to centric occlusion. So, put it in other words, her centric occlusion is just a little bit too forward from where it should be. But, considering that this was a skeletal open bite and we had no references other than radiologic to create a perfectly functional class 1 occlusion, this is a good result. And always in May 17, I keep checking with a classical polygraphic scan, her swallow, and I see that the masseters and temporalis, they activate, and more or less, but maybe a little less, by a 0.5 millimeter, she doesn't really go to centric occlusion when closing and swallowing, okay? She does come a little forward. It's a little wiggly here, but it's okay. I mean, this is a voluntary swallow. I don't see that big pathological sequence. But if I use only electromyography and I start testing the upper and the lower perioral musculature, I see that the lower perioral musculature really activates before the temporal and the masseter musculature. I see that the upper and lower perioral musculature during a spontaneous swallow of saliva really activate a little bit early. But I try not to think about it. I'm very suspicious though, okay? I have her come back in 2024. Okay. That means now we're about 12 years from surgery. And I want to show you what happens. In a voluntary swallow of saliva, she activates the submental musculature very well, and there's really no activation of the perioral musculature. She is very good in doing this. What I see is that I can't get her to relax completely. There's not enough freeway space, very little. That means something happened that I cannot visualize in this particular moment. I have to study her a little and get closer to a little bit more. So what I do is I wait for a spontaneous swallow of saliva that you see here, and then I ask her again in the sweep mode that you see, just going from your left to right, okay? The sweep mode, I asked her after the spontaneous swallow to do a voluntary swallow of saliva, so you can see in one shot what's going on. And if we look at the spontaneous swallow of saliva, we immediately see that the lower perioral musculature is activated way before the submental musculature. And that output that you see, the red one here, the red line, is a big, strong output. And it's way before also the temporal and mandibular activation, okay? And this is already indicative, from my point of view, of a primary swallow dysfunction. If I ask her to swallow, then she is conscious, it's not spontaneous. What I get here is that, again, they're all on the same line, okay? Yes, we do have an activation of the perioral musculature, but we also have a good activation of the submental musculature, the temporal musculature activate, and the masseter activate, okay? These activate more or less on the same line. There's not that early activation of the perioral musculature. And the total output that we have of the lower, of the submental musculature is, yes, very important. It matches or is slightly more than the lower perioral musculature activation. And this is already indicative of a primary tongue dysfunction. And I can check this again, and I do check it, voluntary swallow of saliva. There you go. These are the activation of the submental. The others activate very little. And this is a demonstration that with voluntary, this is our result. Okay. And if we go forward, I check again the spontaneous swallow of saliva, and again you see this, the lower perioral, okay, really activate early, much before the temporalis. And look at the submental that have that strong late activation, okay? This is indicative of the swallow disorder I'm trying to define with my research. And again, we can see this again. This is a spontaneous swallow of saliva. This is the late activation of the submental, but a very strong early activation of the perioral. This is a little bit more difficult to see. This can be seen and interpreted as a very high output of the perioral versus a lower output of the submental. So if you remember that table I showed you, this is another characteristic of the spontaneous swallow. And when we look at the occlusion, of course, this is the result. It's called relapse. From class 1, now we have a class 2 occlusion, and now that little opening has become bigger, and now there's really nothing we can do. There's no surgery, no orthodontics, because that is how the tongue functions. And I talked with my patient, And she was very happy anyway. She was positive with her very positive with her occlusion, how she smiled and didn't care anymore. And she was happy anyway after 12 years of the result, and she accepted it. And it would have been much better for me to have told her before surgery, listen, I've done electromyography. I know your tongue thrust could be primary tongue dysfunction, so you might have relapse after 10 years or 15 years or even earlier. And I can't tell you how much that relapse is going to be, and if it's going to be a relapse that is so important that we actually fail in doing all this, or if it's going to be a very light relapse after 10 or 15 years that you accept. That would be a fair discussion with your patient. On the other hand, if it's an orthodontic treatment, I would, in certain cases, avoid to treat these patients. And quite frankly, in the last 5 or 7 years, I have avoided to treat class 2 occlusions that have a dysfunction, a tongue dysfunction like I have been describing you. So the study aimed at describing and defining primary tongue thrust, which is not recognized by everybody. What could the explanation of this primary tongue thrust be? As you see from the electromyography, you see that generally the upper and lower perioral musculature is activated well before the other musculature involved in the oral phase of deglutition, and this premature activation could be a physiological response from the central nervous system that knows that there is a tongue dysfunction, that knows that there is no way to override that tongue dysfunction, and warns the perioral musculature to contract in a vigorous manner in order to not lose food from the oral cavity, which is, of course, a survival feature of the physiology of the human being. Please send me your questions at savastano@savasystem.com. I'd like to thank everybody here for standing me for over 40 minutes. I've probably been a little heavy for all of you, and I hope some of you find interest. I will continue the study until I have the physical ability and temper to do so. Thank you very much.
Thank you, Fabio, for your very, very interesting presentation, for your lecture on evidence-based dentistry on surface electromyographic recording.
Definitely a great presentation. Thank you again.